Hey everybody, I'm just going to give you a quick not checklist, but some ways that you can really prioritize and make your assessments much more efficient and effective. And I think no matter how many years of experience you have, I think we all could benefit from some more efficiency in our assessment. And if you've listened to the podcast often enough and are in our mentor program, you'll know that we talk a lot about past movement history. So the PMH for me is past movement history. And I really go into the depth and, really ask a ton of questions on past injuries. And I think it's best if I just give you a story or a history, and apologies if you hear the noise in the background. I do live in New York City. So this was a guy I treated recently. He's a sort of a competitive athlete, middle-aged athlete, and actually had a cyclist, a triathlete, and had a lot of low back pain, really worse on the left, no major leg pain, but had some foot numbness on his left foot. And the main issue was sitting. He just really couldn't sit. Can you imagine being on the bike in a triathlon and you can't sit? So that was his main complaint. Got worse after the knee arthroscopy that he had in January of this year. So right knee arthroscopy, left side low back pain and foot numbness got worse after. Past medical history, past movement history, left knee arthroscopy about 7 years ago, and a C3-4 discectomy about 15 years ago, maybe. And so that was his past movement history. Those were his past injuries. He's had a few falls off the bike, right? Some hip issues. But the main issue was the both knee scopes and his low back symptoms. That was his pain generator, and he had a neck issue. So when I had him in standing, he was significantly translated to the left. Not surprising, right? The right knee scope just made him translate his body to the other side. Common, that's normal, right? My guess is, looking at him, I started him in telehealth, that movement pattern was there for years. He was so significantly translated in his thoracic spine, it wasn't even funny. Okay, so this guy had back pain. So on my list, okay, just because of what I saw, I have to look at his upper quarter, right? His thorax, his shoulder. I had him stand posteriorly to the camera. His left shoulder scapula, the upper trap tone, and the significant internal rotation on his left side was, for lack of a better word, not even a clinical word, ginormous. It was like this. Relevant, right? Could it be from the C3-4 discectomy years ago? Maybe. Because he had the surgery, it's an area of the body that I need to assess. The neck and that shoulder girdle and the thorax, just based on that alone. And this guy has back pain, so I would be doing him a disservice if I did not look at the neck and that shoulder complex, because he's sitting on a bike, right? That is important, and those are hard to do for people who have neck issues. This guy had a low back issue, but in my experience, I've seen neck dysfunction drive lumbar spine dysfunction, right? So the main issues from a priority standpoint, I would look at his knee, obviously, but I do think it was a learned movement pattern. In my experience, knees are not generally responsible for lumbar pain, but I would look at it because I want to be thorough. But high on my list would be the thorax, the shoulder, and the neck, because of his past injury history there. Why is he translated to the left? It's a learned movement pattern. I would assess his lumbar spine, but because, in my experience, the lumbar spine is generally not the driver of these persistent issues. It could be a secondary issue. I would look at it. It's a meaningful area for him. You have to have, the patients need to be heard and felt. So I would look at that. But I'm trying to give you guys just an idea of what I would really prioritize, because you will miss something if you don't look at the areas that may not coincide, but may be playing into his dysfunction. That left shoulder issue was so obvious. And it made sense coming from the neck with all that tone there. It was something that I did actually end up assessing. Okay, and I will tell you, when I finished, I determined that there are two drivers. Well, the primary was his thorax. And because when I, corrected him and translated him, got him back on his feet, his meaningful movement, which was a squat, was significantly better. I also worked the neck. The neck is a secondary issue because when I actually ended up getting him centered over, his neck actually looked a little worse. So when you see something like that in an area of the body that's getting worse, then you generally don't, you have two issues. You have two drivers, okay? I know this may be a little bit complex, but I just wanted to get you to sort of think out of the box a bit and think about other areas, past movement, past medical history, past movement history, past injuries as potential drivers. So I put those on the priority list. Hope it helps.